sent me a text message that there's an outage for Zoom in Montgomery County. So we're freaking out a little bit, you know, and, but I think if I had a crystal ball, I think that is going to be coming soon, is that we're all going to freak out because in a couple of weeks, there's going to be some outage of Zoom, and it's our lifeline to connect with each other. So I want to jump right into this program. We've got Dr. Alex Mohseni, who many of you are familiar with now, has been really helpful in kind of helping us navigate this COVID-19. And the topic today is really critical for all of us to learn about. It's critical for us to all know about all forms of technology that can better help us connect with our clients, especially when they're in long-term care settings or senior living settings or what have you. And so Alex is going to give us an overview of what remote patient monitoring is, also referred to as RPM, is. And then we should have time afterwards to kind of have our typical open discussion. So be thinking about topics or questions or concerns that you might be faced with. As just a reminder, you can interact in several different ways. You can raise your hand and we can call on you. You can use the Q&A function, or you can comment. But when you're commenting, one important thing, it's a good idea to comment to moderators and participants. That way everybody can see, chat, when you chat, that way everybody can see what you're talking about. And a lot of times our participants are the ones with the best questions. And let's see, Ken Silverstein's already got his hand raised. So before we put Alex on, let's see if Ken's got a question or concern. Ken, can you hear me? Ken?
Sorry, I forgot to unmute.
Oh, okay, great.
So I just want to let you know I'm in Montgomery County, and I just got off an 11 o'clock Zoom meeting, and I'm on with you guys. So
awesome.
And I'm not by any means understand this technology, so but
that's great.
So maybe coming up is my wife's name, Mindy. I'm on her computer because I'm working from home. So
okay, well, great. Thanks a lot, Ken. And
sure. Thanks for doing this.
You bet. Okay. I think Alex and I are hoping that this warning that we heard about with Zoom going out is for the web version and not necessarily the native app version that we're on. So Alex, I'm gonna move to the background and take it away, buddy.
Great, thank you. Thank you so much, Steve. Give me one moment to switch to my screen here. 1 second. All right, Steve, is my screen visible?
Yep.
Okay, perfect. So welcome everybody. My name is Alex Mohseni. I'm an emergency medicine physician. I'm the co-host of Mastering Medicare, a podcast that Dr. Amy Schiffman and I recently launched, helping senior serving professionals and physicians understand many of the nuances of healthcare and especially the payer world. And I'm also the medical director of Accuhealth, which is a remote patient monitoring company. And I'm very excited to talk to you guys about this today. We've done a different webinar that was focused more for physician providers. Today's talk is specifically geared towards senior serving professionals and what those folks need to know about remote patient monitoring. So this is pretty brief. Hopefully we'll have plenty of time to chat and answer your questions. So here's the agenda we're going to go through. What is remote patient monitoring? What is the role of RPM in COVID-19? Who can order RPM? How do my clients, patients, and residents benefit from RPM? What is the role of facility staff in RPM? How do I benefit from RPM? And by I meaning if you're in the operations or leadership of a senior housing solution? And what if my client's doctor doesn't know about RPM? So these are the questions I'm going to hopefully answer for you today. All right, so what is remote patient monitoring? So before I describe for you what it is, let me clarify that remote patient monitoring goes by two other common names as well. One is remote physiologic monitoring, and that is the terminology that you might see in the Medicare literature. And you might also hear the phrase telemonitoring. And the concept is quite simple. It's providing the patient a monitoring device like a blood pressure machine or a glucometer or a weight scale or pulse ox or respiratory rate monitor, and having that data flow back electronically back to the ordering physician, and then having the ordering physician or provider communicate and interact back with the patient. So there's a device that's with the patient in the patient's home, and the patient is generally expected to check their physiological parameter at least typically once a day. That data, that machine has to be FDA approved. It has to send its data through the airwaves back to the office. So this is different from self-reported data. So technically the RPM codes do not apply if somebody is typing in their blood pressure and sending that to their doctor. That's a different type of monitoring. And then the ordering provider needs, again, to review that data, compare it to past data, and interact back with the patient. So, for example, here's one of the machines that we use. If you see my video screen, and later on we can go to full screen video, but it's very simple. It looks like any other normal blood pressure machine, but what's special about this machine is that when I take a reading, instead of it just showing the data to me and nothing else, it also automatically sends the data to my physician. So who pays for remote physiologic monitoring or remote patient monitoring, RPM? So RPM is a Part B service. Medicare and Medicare Advantage, for the most part, unless you're in a special program, generally pay for this. Many, if not most, private payers are paying for this. There are some exceptions. As I said, there's a few special Medicare populations that are under special reimbursement programs where this might not apply. And as far as we can tell, the VA does not pay for RPM. And who they're paying is the physician for ordering and managing this service. So what is the role of RPM in COVID-19? Why are we even talking about this? Well, obviously, as you guys know, right now, many patients are being told to stay at home and not go out unless absolutely necessary. And even routine office visits are being missed by many patients or not even being scheduled. And rightly so, people are scared to go out, and they should be scared. Yet the need to continue to monitor these patients and their vital signs still exists. And so RPM was really created by, these new codes were created by Medicare recently in the last 2 or 3 years. And in this year, in 2020, Medicare modified the rules to be a lot easier for physicians to actually manage this sort of program, because starting this year, Medicare allows physicians to essentially outsource much of the technical work to a vendor partner so that the physician can focus just on responding to the physiological parameters and not have to deal with the complexity of managing devices and Bluetooth and all that sort of silly stuff. So what role does RPM have in COVID-19? It's pretty obvious. The most important role is to monitor the patient's vital sign at home. And the vital signs we care the most about with COVID are respiratory rate, pulse ox, and heart rate. Pulse ox is also called SpO2 or oxygen saturation. Respiratory rate is obviously how fast you are breathing, and then heart rate as well. So we care about these because we know that the key thing that we care about with COVID-19 is not just who has it, but what we worry about is respiratory failure. and an increased respiratory rate or a low oxygen saturation or a high heart rate can be indicators of impending respiratory failure. With RPM, we also can monitor other vital signs. We can monitor blood pressure, blood sugar, weight, and some creative people are finding even other things to monitor, like temperature, and there's a few other ones that I won't get into right now. So again, the main reason we care about this is because we can't possibly hospitalize every senior who is COVID positive or suspected to be COVID positive. Most are going to need to be sent home. So how are we going to keep an eye on them and know when they start to decline? Because the decline with COVID-19 is extremely rapid with some people. Within a number of hours, they can go from relatively clinically stable to full-blown respiratory failure and death. And so we need to be able to watch out for that and be able to intervene as fast as possible. The other main reason that we care about RPM, other than the specific physiological parameter like respiratory rate, is that we've learned with RPM, when you start monitoring one physiologic parameter with a patient, there is a halo effect where the patient starts to care and pay more attention to all of their physiology. They tend to care more about their lifestyle choices, the foods they eat, the exercise that they do. So the halo effect of being more closely connected to your doctor, knowing that there is some data flowing back and forth, and you have increased touch points, and now there might even be some accountability where somebody else is looking at your numbers closely, it changes behavior. So who can order remote patient monitoring? Essentially, any qualified healthcare practitioner can. But most commonly, we see this specifically with primary care doctors, which includes house call providers, cardiologists, endocrinologists, pulmonologists, and then some hospitals are starting to get into this as well, because when they are discharging patients, they are trying to stay connected to the discharges, and this helps them or can help them with reducing 30-day readmissions. How do my clients, patients / residents benefit from RPM? So this is a great question, and there are many benefits to having your patient be on an RPM program with their provider, especially their primary care provider. As I mentioned before, as opposed to the kind of normal cadence where a patient might see their primary care doctor only maybe once every 6 months, now the cadence of data and information and feedback is almost on a daily basis. And that increased cadence of feedback means there's many more touch points with the provider. And we know that the more touch points between the provider and the patient, the more data, the better the quality of that data, then the better healthcare outcomes we're going to have. As I said earlier as well, there's increased accountability for the health decisions of the patient. And what we've also noticed, which is an unintended consequence, which is that having those frequent touch points with the patient also impacts loneliness. For some, the phone you get from the remote patient monitoring company about their daily physiology might be the only phone call or human interaction they get that day. It's for that reason that in our company, we try to call the senior from using the same staff person from our clinical team, because we've learned that that clinical person from our team can develop a relationship with the senior, and that relationship is very valuable to both parties. So what is the role of the facility staff in RPM? There are several things that facility staff can help with in any RPM program. First is with assisting with patient onboarding. So for example, our company, we ship the device or devices to the patient's house or to their assisted living using FedEx, and any sort of help that can be provided in terms of opening that package and helping the patient take their first measurement. And we call the patient always to help them take that first measurement, but any sort of assistance in that process is greatly appreciated. Some remote patient monitoring companies use systems that require a tablet, Bluetooth, and Wi-Fi, and it can be kind of complicated and it can be difficult, especially for seniors who aren't good with technology. We take the approach of using cellular devices that have a built-in cellular chip that sends the data automatically back to the home base without needing any sort of smartphone, Bluetooth, Wi-Fi app or download or login of any sort, but not all RPM companies are that way. So the onboarding and the account access portion can be a barrier, and that is one thing that facility team members can help with. Next is when, as you can imagine, when seniors are taking their measurements, sometimes those measurements are going to be abnormal. The blood pressure might be high, it might be 200, the blood sugar might be high or low. And what's important when there's an abnormal number is that there's a lot of clinical decision making that needs to happen to figure out how to respond to that. So when that abnormal number is taken, it gets sent to the remote patient monitoring clinical team, and the clinical team is going to look at that number, and typically what they're going to do is pick up the phone and call the senior, and they're either going to speak with the senior or the caregiver depending on the situation, and try to figure out what is going on here and do we need to escalate anything to the physician. So this is where the staff can be very helpful, because the staff are the eyes and ears, and they can communicate. Is the resident behaving normally? Are they in any pain? Did they miss any medication? Are they nauseous? Are they diaphoretic? You know, how do they feel? How do they look? Is there any explanation for this abnormal number? Or sometimes something totally unexpected, maybe somebody else, another resident, borrowed the device and took a measurement, and it wasn't even the resident we thought it was. So having boots on the ground to help with that, those sort of questions can be extremely helpful. Next is many providers in the community still don't even know about this program and the availability of RPM. And this is a shame, because it's a great opportunity to be better connected to, for physicians to be better connected to their patients. And so the more we can do in terms of having staff and facility leadership communicate to the providers that they're connected with that, hey, are you doing an RPM program? And if not, why not? You know, there's really no negative to this. As you can imagine, the main initial reaction from many physicians is that, oh my gosh, don't even tell me about a new program. My brain is full. I can't possibly learn a new thing. And that reaction is understandable given how complicated and difficult the primary care and other specialty practices are. But that is the role of the RPM partner companies, like the one that I work for, to help alleviate all the friction points and stressors, so that this can actually be a very easy and highly rewarding program for everybody. The last thing I would like to say for the facility staff is these devices that are sent for patients are, for the most part, registered to supply data automatically back to the practice. So it's really important that that device be only used for that patient and not accidentally taken out of the patient's room and used for somebody else, because otherwise all the data is going to get mixed up, and that doesn't help anybody. So we recommend for any senior who does participate in an RPM program, if they are in an environment where there are other seniors, then either the senior or staff should help with putting a label on that device with the patient's name, so that everybody knows that that device is specific only to that resident. So how do I or you benefit from RPM? Meaning if you manage a facility or you are a senior serving professional, why should you care about this? And let me, if it's not obvious, let me try to communicate what some of those reasons are. Because you're increasing the number of touch points between the physician and the patient and the halo effect and the change in behavior, for the most part, a good RPM program is going to result in healthier clients, healthier residents. And that means your client base is going to be more stable. You know, nothing causes, I think, more instability than a medical emergency. And you're going to hopefully have fewer medical emergencies. As well, additionally, the healthier your clients and residents are, the happier they're going to be, and the happier their families are going to be. And that means your job is going to be easier. Because again, nothing causes more stress for the resident and everybody around them and their families than a medical emergency. And the last benefit is by having this conduit, this junction point that's a daily node of interaction with the provider team, now you have an easier way to connect with the provider, and your job is easier from that perspective as well. Because very often with an RPM program, the senior is going to be receiving several phone calls a week from either the physician practice or the RPM vendor, checking on them to making sure they're okay. And let's say the senior is being monitored for blood pressure, and their only RPM device is blood pressure. Even though the phone call might come in to just talk to the patient or resident about blood pressure, that is still an opportunity for the care team or the caregiver to join the phone call and say, hey, you know, Mary's blood pressure is doing fine, but I'm concerned about this new thing that I saw, or I'm worried about X, Y, and Z. What do you think we should do about that? And then that can be communicated back to the physician. So it makes it easier for you to communicate back to the physician. And we think that's extremely, extremely valuable. So what if your client's physician or provider doesn't know about remote patient monitoring? And it's very likely they may have heard about it, but most physicians have yet to really implement an RPM program. And as I said, it's obvious why. They're overwhelmed, and the cognitive load on many providers is overwhelming, especially in this COVID-19 era. But what we're trying to do is to go out to the community, communicate the power and positive outcomes that we have with this sort of program and the benefits to everybody all around. And we're trying to make it easy. So feel free to share. Amy and I recently did a podcast about this. You can find it on our website, masteringmedicare.net. It was podcast episode number 6. We just did a webinar with the Montgomery County Medical Society. I put the link here on this slide, which I think Steve can share with all of you guys. That is geared towards the physician audience. And then obviously, please feel free to share my contact information, alex@masteringmedicare.net. I'm happy to talk to anybody about this program, whether on the provider side or the senior serving professional side. That's all I have for you. And I think we're going to go to some questions and conversation.
Awesome. Great job, Alex. And really, a really great example for future presenters, you know, getting right to the point and addressing those questions, and knock that out in less than 20 minutes, which is the attention span of many people. Alex, you can see Katie Curtis asks, does Medicare B cover DME needed to monitor VS? And that's durable medical equipment. And
okay, yeah. So in a typical RPM program, what typically happens is that the provider is going to partner with an RPM company like mine. Mine is called Accuhealth.tech. They're going to choose an RPM company, and that company has a set of devices and a system. And the physician is typically going to use just one company to keep things simple. And every time they have a patient whom they would like to put on RPM, they're going to order that sort of specific device. And we don't call it DME. It is just the RPM device. And they're going to, and it's all one ecosystem, because the device needs to not just send the data back to the provider, but it's got to go through the EMR. So you need an EMR integration, and a good RPM vendor will also allow the physician to order the specific RPM device with specific threshold parameters directly from their EMR. So the doctor will partner with a vendor, and the vendor will usually ship and manage everything having to do with the device. Some vendors have a clinical team, some do not. So hopefully I answered that question. Can INR be done with RPM? No, INR is not considered one of the physiological parameters for RPM. INR monitoring can be done under other codes. I'm not an expert on the INR codes, but INR is generally not considered to be under the RPM umbrella. RPM codes, there are 3 monthly recurring codes: 99454, 457, and 458. Those are the main codes for RPM. INR stuff is all done underneath other codes.
What is, for somebody that's not fully in this world, what is INR?
It's when somebody is on Coumadin, also called warfarin, which is a blood thinner typically given after a stroke or a blood clot in the lung or in the leg. Then somebody needs to basically check the thinness of their blood, and the INR check, the International Normalized Ratio, is what it really stands for. It's a blood check to make sure that your Coumadin level, that's what lay people call it, their Coumadin level, that their Coumadin level is normal, because otherwise they may need to adjust the dose of their medication.
Do you see the question from Shannon Dujon from Sunnyside Manor? Who initiates the process? Can a provider initiate a relationship with a vendor and recommend the service to a physician?
By provider, you're meaning non-physician?
Like an assisted living, could an assisted living recommend the relationship?
Yeah, the actual RPM, the order for RPM needs to come from a physician, but anybody can go to the physician and say, hey, why are you not doing this? You know, we want it, we'll help support, we'll help support the program. And, you should know physicians can make money off this, just like they can make money off of any other thing. It's really a cognitive load and mind share issue. So if you can communicate, the key thing to communicate to the physician is that, listen, this is a valuable program that we think would really benefit our residents. And there are companies out there that can make this easy for everybody, easy for us at the facility, easy for you as a physician, because that is the biggest fear, that it's too complicated for me.
Can you see the Mary Ellen from the medical team states they've been using RPM in home health care since 2011. Alas, Medicare does not cover it for home health care. Info communicates with office and the cardiac nurse's phone. Nurse sends graphs and info to primary care physician at time of appointment.
I'm not sure what the question is there, but let me communicate.
I think she was making more of a statement there.
Yeah, but I do see a question. This technology has been around for a while. What have been the barriers to implementation? The main barrier to implementation in the last, I'd say, 2 years has been that the rule before January 1st, 2020 was that RPM had to be done under direct supervision, and much of the work had to be done by higher level, meaning more expensive staff like the physician or PA or NP themselves. Starting January 1st of 2020, the rule changed, and now the rule is that this can be done under what's called general supervision of clinical staff. And if you put that all together, what it really means is that the majority of the work can be outsourced to a vendor. So the only thing the physician has to do is 2 things. One, they got to order the right monitoring for the right patient. And then when there is an alert that something is wrong with the patient, they need to respond to that. The vendors can now handle everything else, including the daily monitoring and interaction of every data point, because the doctor does not have time to look at every single blood pressure every day. The only time they really need to know is that when there's something significantly abnormal, right? And now you can do that. This model was not possible before January 1st of this year.
We've had a few questions about finding a list of vendors, and you'd mentioned you represent one company that does this, but which obviously,
Yeah.
anybody
So
who's interested can contact Alex directly. But I know in some companies there might be is there in general like a traditional RFP process where people talk to multiple vendors, or how does
yeah,
that?
there are probably more than 100 RPM vendors out there. And let me switch my hats and kind of tell you what I think about what's going on out there. Just put RPM vendor, in Google, and you'll see 100 companies come out there. What you will generally see out there are a mix of a few things going on. So keep this is what I want you to think about when you look when you're assessing a vendor option. There are some vendors that have started out as CCM companies and said, okay, well, we can do RPM. All it means is we got to get some devices. So they hobble together some Bluetooth devices and then ship over a whole package with a complicated tablet. And they expect somebody to put together the Wi-Fi, the Bluetooth, and a login and password and an app and all that. So what I care about and what I've seen is if the system is not simple, it's not going to work. So make sure when you're assessing a vendor, you ask yourself, would the senior or the caregiver actually be able to manage all of the technology that's being proposed? That I think is the most important thing. So think about, is this, because what you're gonna see out there are a ton of companies that have a lot of bells and whistles. But with more bells and whistles also comes increased complexity, and with increased complexity comes decreased usability. So keep that in mind.
Did we answer the Part B copayment question on?
Yeah, so this is for some reason, I'm not seeing all the questions, but this is a Part B service. So just like everything else, there is the 20% that the patient will be responsible for unless they have supplemental insurance. There is some talk that this co-insurance or copay, whatever you call it, might get waived. There's a lot of kind of new changes happening every other day with CMS, but I have not yet seen that the RPM co-insurance, that I have not seen any rule that the RPM co-insurance is going to be waived yet, but I have seen talk about it.
And I'm going to post it, but what is the name of your RPM company?
Accuhealth.tech.
Okay, I'll make sure to repost that, and we'll make sure that we get Alex's contact info to you.
Another common barrier when you're looking at vendors is who's going to pay for the device. And as I said, some RPM companies use very complicated devices that are relatively expensive, and they will expect the provider, meaning the physician practice, or the patient to pay for the device. We used to do that, and we saw that was a barrier, so we have stopped doing that. We paid for the first device for each patient. And another thing I would think about is, how do you keep patients engaged and excited about this? Because it's easy to do anything new for maybe a week or two, but what about month 2, month 6, month 9? How do you keep somebody engaged and excited about taking their blood pressure every day? We do some cool and fun stuff. Like we have the seniors participate in a bingo game where every day where they take a measurement, they get a bingo token, and then they can win all sorts of gift cards up to even $500. So that's how we do it. I know there's a couple other RPM companies that try to gamify it too, which I love. I love that people are thinking creatively about how to get seniors engaged and excited about this. Is there a Part B copayment? Yes, we answered that.
Oh, the POA, does it need to be approved by the resident's family or POA?
Great question. There are some rules with what the physician has to do. The physician must have had a face-to-face encounter with the patient in the last 12 months in order to order RPM. And now it could be, the interpretation now is that face-to-face could even potentially happen via telemedicine if they haven't been in the office in the last 12 months. And then the physician does need to obtain verbal consent from the patient or whoever is representing the patient, either as a POA or other representative, the physician does need to get verbal consent, because there is the patient Part B responsibility, and the physician needs to document that verbal consent. Great question.
Cool. Man, thanks everybody. I think those were some awesome questions, and you can still jump in with any RPM questions, but I'd like to shift the dialogue, open the door at least, to shift the dialogue to anything that you want to talk about. If you've got something you want to share related to COVID challenges, if you got a question, by all means, let's use the remaining time that we have to engage that way. I will bring up right before this webinar, I received a call from a provider who was asking, is there a list of all of the COVID-19, all the communities that have tested and acknowledged that they have COVID-19 positive residents? And at this point, there's not a complete database of that. I think we're all basically seeing the news reports, and when one comes by my way, I post it to the new ProAging community. But I think what we all know is that probably because there's not widespread testing, more than likely there's COVID positive people in every community. I think the important thing is how communities, the policies, the protocols that they have in place. And one project that I'm working on with Dr. Amy and Dr. Alex is sort of trying to create an easy to use database so that we can all post what's going on in our communities, and we can all check out, oh, this is how Shady Acres is dealing with COVID-19 or what have you. So I just wanted to throw that out. Anita Rothwell just shared the list of communities with positive tests in Montgomery County is on this website here. I'm gonna try to post this to all the comments, and I'll share that as well. There, I just did that to everybody. But so feel free to raise your hand if you've got if you'd like to make a comment or question. Let's see, we've got yeah, I guess this is a good one, Alex. How is this getting expanded during COVID-19? Can new clients get on RPM during this pandemic? Is it possible for a physician to get online like this week?
We have maybe 10 or more practices a day joining us right now, because practices are realizing almost in a panic mode right now that their offices are empty. The patients can't or don't want to come into the office, and the practices need some way to figure out how to connect with these patients and provide them the care that they need. So we try to get them up and running typically within 2 or 3 days. We integrate with almost every EMR, so it's all about making this simple and easy for everybody. So without a doubt, with COVID-19, it has been a skyrocketing demand and interest in RPM over the last few weeks. Yet, it's still a relatively small number of providers who even know about this.
Yeah. So I think, one of the benefits of hosting this webinar, especially now, and one of the reasons that we wanted to do this is it's I don't want to call it pressure, but if senior providers who are taking care of older adults are communicating to the physician community about this technology, that will not only be a game changer for the physicians, encouraging them, but it enables us as providers to better make sure that the safety of our residents and the health of our residents are better. You can really see where a homebound isolated patient with RPM, it's going to be much easier to identify symptoms of COVID-19 than otherwise. Let's see, and again, Heather Surrey is mentioning Fox Trail as a community that has really put together some good materials to share how they're dealing with this epidemic. And that's this project that we're working on. That's kind of our goal is that if we can create a platform where everybody can share their policies, it's going to raise the bar on how all communities are treating and handling potential residents moving in and out. Let's see, Patricia is saying, I'd love to hear who else is on the webinar. Can you open up the participants for some networking? Absolutely. All you got to do is just raise your hand, guys, and you'll see the button that says raise hand. And we've got a few minutes where we can look at that, man. It's all I had to do. So let's go down the list here and we'll try to use our remaining time as wisely as possible. Okay, so Mary Ellen, can you hear me?
Yes, I can.
Okay, great. Tell us who you are and got anything to share with the group.
Yeah, I'm still confused about the RPM, but I was looking on his website to see if I could figure it out. How what we have been doing at the medical team is, we have a very advanced practice cardiac nurse. In your system, who goes straight to the PCP's office, and then the office staff is responsible for triaging what's
okay. Well, in the way we do it, and the way most RPM companies do it, is that the data first comes from the patient to the RPM vendor's platform. And the first line of interaction is the RPM vendor's own clinical staff. And they're they're picking up the phone, calling the senior, and figuring out, is this signal or is this noise? Meaning, is there something truly abnormal and important here? For the most part, I'd say more than 90% of the time, it's nothing critical. Maybe the patient forgot to take a dose of their medication. They just need to be reminded to take their medicine. They recheck the number an hour later, everything's fine. But when they do recognize that, hey, there is or there could be something abnormal here, then they escalate an alert to the physician. So that's how we reduce the kind of workload on the physician.
Okay. Yeah, we had a lot of people, son-in-law standing on the scales that we use. So we had to educate on
right. That happens.
Yeah.
Okay. Thanks, Mary Ellen. Let's go to Sharon. Sharon, can you hear me? Sharon?
Are you hearing me now?
Yep. Hey, Sharon.
Mute can mess you up sometimes,
Yeah.
So I'm a smaller provider, and one of the challenges that I have faced is it almost felt a little bullying with some of the nursing staff, like the home care services that need to come in to see my clients. When I set a standard, they almost don't want to respect that. So I've had to become a little bit serious about it and really walk people away, because they're coming from multiple locations and coming into smaller facilities. And my priority is my resident, and I'm going to do whatever is necessary to protect them. I don't know if you have any guidance or advice on. I had a phlebotomist call this morning and telling me I'm coming. I'm over in Laurel and I'm coming over next. And I said, no. We really didn't need that.
I mean, thank you for sharing that. And I think we've heard this time and time again. I think the community where the residents are living, it's really, they're the most responsible party there in terms of the safety of their residents. And so as providers, we need to adhere to their protocol. But I think providers connecting with each other and trying to understand what the best protocol is and the ways that we can enforce it is really key. Obviously, we can't solve this problem here, but I'm glad we threw that out. And this is the other thing is that if you haven't joined the new ProAging online community, this is the kind of dialogue that we can kind of get going together and maybe come up with some solutions. But I would say to any providers, and probably the ones on this webinar are not the violators, but is to have a dialogue with the communities that your clients are in or that you're trying to serve, as opposed to sort of being like a bull in the china shop, I think is the best way to do it. Let's see. Bonnie Elliott. Bonnie, can you hear? Bonnie?
Sorry, here I am.
Okay, great. Hey, Bonnie.
Hi. So I was just typing in the chat box. So sorry, I should say I'm from Care Patrol of Central Maryland in Loudoun, Virginia, and we help families find senior care options, including all the community resources like RPMs. And we're partnering actually with one, not to take anything away from you, Alex, great job, wonderful information. But, and I don't know if you know this company, but it's called Push Button Care.
I don't know them personally.
Okay, so I posted on the website a day or two ago, and I was just putting it in the chat box, but it's just another option if you're shopping around and comparing, and you know, it might have some different sorts of services, or it might be priced differently. I'm really not sure, but just check it out to do your due diligence if you're looking into some different ones, some different options.
Awesome. No, it's great to hear from another provider who's experienced at this. All right, let's see. LaVerge. LaVerge?
Hi, it's Laverne.
Oh, Laverne. Okay, sorry.
Yeah, I'm a mobile podiatrist, and I am not using the RCM. I don't really need to monitor patients like that because I'm not taking care of anyone who has any chronic conditions. So, but this was very informative. Thank you.
Well, I do want to say actually that I just found a company that has created a monitoring sock for like diabetic foot ulcer patients, which can be a very serious medical issue. So there is now a podiatry remote patient monitoring sock, which I would have never imagined.
Wonderful.
Oh.
I would love more information on that.
Awesome.
I forget the name of it, but yeah, search Google. If you don't find it, reach out to me. But yeah, I was kind of blown away.
Yeah, and just so you guys know, I mean, we'll send contact info for Alex, but also it's Alex at masteringmedicare.net, correct?
Yes.
Yep. Okay, let's see, Patricia.
Hi, everybody. Just wanted to give big kudos to the presenter and to you, Steve, for a great presentation and for allowing us to be able to hear. Oops, I'm sorry. I dropped my microphone. For allowing us to learn more about this really important aspect of telemedicine. I just, you know, my mom has a defibrillator, so I know that, you know, she plugs in and it sends it back to her doctor's office and they can read what's going on in her system, but I never really thought about it as like, oh, there's so many other forms of medicine that this could be part of. So kudos to you on that information. And keep in mind that if you do have family and friends that need some support, we have upped our protocols with our certified nursing aides so that we can serve all families, and we serve equitably. So please.
What's the name of your company, Patricia?
Oh, thanks, Steve. It's Assisting Hands Home Care, and we serve Montgomery County. So please feel free to reach out. I'm happy to take calls. I left my phone stuff in the chat. So
great. Okay.
I want to make a quick comment on what Patricia said because it's important. There are other codes outside of the RPM codes for specific types of physiological monitoring outside of the ones that I just mentioned, and those have existed longer than RPM. So, for example, What she mentioned, the monitoring of defibrillators and pacemakers, those are, they have their own separate monitoring codes. And there's a separate code for continuous glucose monitoring, which is different from RPM. So with all of this, there's nuance, and obviously this is not the platform for us to go into all that detail, but I do want to share that there are other additional codes that are sometimes more specific and supersede the RPM codes.
Thank you. Okay, Catherine. We got Catherine.
Can you hear me now?
Yep.
Hi, Catherine McCallum, Core Life Strategies. Doctor, great presentation. A couple of questions. You mentioned working with care teams, and when I was the executive director of a village and focusing on aging in place, which I continue to be focused on, there, you know, just in hearing you talk about these different ways of monitoring, and you had mentioned a care team, how does your company loop in a care team? Or do you expect the family care team that's created either by the home health aid company or the family member themselves or the doctors, who is in charge of looping all this in?
Great question. What we try to do is when we onboard a patient, then we try to understand what sort of person is this? And when we try to call that person, are we going to speaking directly with this person, or are we going to be calling a family member or caregiver? So in the onboarding process, we're going to try to understand who the patient or resident is and who the main touch point for communication is going to be. So if that's going to be potentially is that a specific person in the facility? Is it a certain phone number that we should always call if they're, you know, the resident somewhere? Maybe we should always be calling the daughter because the daughter is an at-home caregiver. So we try to figure that out, and we essentially have an algorithm for each patient that we can then follow.
Great, thank you. Thanks, Catherine. Okay, Brad Norris. Brad?
Good afternoon. Hi. Yeah, I work for, excuse me, Homewood Retirement Center at the Martinsburg campus. It was my understanding, based on the leading edge update call, that CMS just recently approved the waiver to extend who can order telehealth and telemedicine, telemonitoring to physician's assistants, certified nursing practitioners, and I forget, but that type of professional, is that accurate?
Yeah, RPM can be ordered. Now, RPM, I want to mention, is different from telehealth. It's technically not under the CMS telehealth umbrella. It's a separate thing. It's not subject to CMS's restrictions on telehealth. And RPM can be ordered by any physician, nurse practitioner, or PA.
Can you, Alex, can you maybe give us a little definition or overview between telehealth and RPM in those definitions?
Yeah, great question. I wish there were an easy answer, but it seems almost, I don't know actually how CMS decides anything these days, but telehealth is more considered to be essentially like the virtual version of a brick and mortar visit between a provider and a patient. RPM has fallen outside of the umbrella. And the reason that's important is that the traditional Medicare has, before COVID-19, had severe restrictions on when a Medicare patient could have a telehealth visit be reimbursable. They had to be outside of a metropolitan statistical area. So essentially that meant they had to be in a rural area, and the senior had to go to an originating site, which means they could not get telehealth from their home. They actually had to go to a doctor's office, which defeats the whole purpose anyway. So it was a ludicrous set of restrictions. Those are temporarily removed right now in the COVID-19 era. Nobody knows what's going to happen after this. I hope those restrictions just disappear because it's ridiculous. But RPM has not been under our telehealth and therefore was not under those rules. Similar to CCM, I'm pretty sure CCM also, you know, chronic care management is also not under the telehealth umbrella. It's actually a separate, and they categorize it under some other name, which I don't actually recall right now. But CCM was not restricted, for example, to folks only in rural areas. We know that. So it's like CCM in that respect.
Okay. Great. And it looks like we'll make this our last participant is Waveen. Waveen?
Yes, this is Wivine.
Hey, Waveen.
Hello. This is my first time hearing about this, so I don't have any question. Just thinking.
Oh, okay, great. Well, thank you. And it's actually really important to learn how to work in Zoom in the modern age. And so, you know, it's great when you know how to raise your hand now in the new world and make a comment. Well, this is awesome. Thank you, Alex. Obviously, this was a great point of discussion. A couple of things just to remind you guys. If you haven't joined the ProAging online community, get over there. The links are in the emails. We've got a awesome webinar calendar. Some of them are things that we're doing, but there's literally dozens of new meetings like this coming together each week. So check that out. And by all means, feel free to reach out to me via email if you've got any questions, comments, suggestions, ways that we can better come together as a community to better embrace the rapid change that's in front of us. And hopefully we covered everything. I recorded this, so I'll send out a link of the recording to everyone. And you've got Dr. Alex's PowerPoints as well coming to you. Again, thanks everybody. We're signing off.
Thank you. Bye-bye.
You bet.